Welcome to this explainer. You know the feeling. A patient comes through the trauma bay doors with a compromised airway or a major electrical, chemical, or thermal injury, and the pressure is immediately on. It's a ticking clock. Every single decision you make in those critical first few hours literally dictates that patient's long-term survival. So today, we're breaking down the exact step-by-step algorithms derived directly from advanced burn life support guidelines. We are going to give you absolute clarity for when the heat is quite literally on. All right, let's dive right in. We've got a lot of ground to cover today. We're going to follow a very structured clinical roadmap, starting with initial assessment and safety, moving through the primary and secondary surveys, tackling those tricky fluid resuscitation formulas, and finally wrapping up with burn center referral criteria and the transfer process itself. So let's start at the very beginning, initial assessment and safety. Look, before we even touch the patient, we have to talk about body substance isolation. I know, it sounds super basic, right? But honestly, in the absolute chaos of a trauma bay, it is so easily overlooked. Depending on how your patient presents, you've got to quickly gauge your own risk of exposure to airborne pathogens, bodily fluids, or lingering chemicals. Think about it. If a patient is covered in a corrosive industrial chemical, jumping in without the proper PPE just turns one patient into two. You absolutely have to secure your own safety first to be of any real help to the person on the stretcher. Once the scene is safe, we immediately transition into the primary survey. The second the patient rolls through those doors, it is go time. For identifying life or limb-threatening injuries, we are strictly following the ABCDE sequence here, and you never move to the next step until the current one is stabilized. Starting with A, airway with C-spine protection. You want to immediately apply 100% oxygen via a non-rebreather mask, especially if you're suspecting an inhalation injury. And of course, protect that C-spine if there's any chance of associated trauma, like a car crash. Next up, B for breathing. Are the lungs, chest wall, and diaphragm actually doing their job? Keep a really close eye out for full-thickness burns around the chest. Those can act like a tight corset and severely restrict breathing. Then C, circulation. Get a read on their blood pressure, pulse, and check the skin color on unburned areas. Step 4, D for disability. This is your quick neurocheck. If they aren't alert, you have to start thinking about carbon monoxide toxicity, hypoxia, or maybe even substance use. And finally, E for exposure. You've got to completely undress the patient to find any hidden injuries. Now, here is a really crucial detail that often gets missed during that circulation step. Before you do any complex math, before you even calculate the total burn area, you need to initiate baseline fluid rates using lactated ringers. It's completely age-based. For the little ones, 5 and under, you start them at 125 milliliters an hour. For kids 6 to 14, bump that up to 250. And for anyone 15 and older, you're starting at 500 milliliters an hour. This right here is your immediate bridge. It gets fluids on board to prevent cardiovascular collapse while you buy time to properly assess the extent of the burns. And while you're managing that exposure step we talked about, stopping the burn process is absolutely essential. Get rid of all clothing, jewelry, diapers, contact lenses, the whole shebang. If something is melted to the skin, cool it down and cut around it. But here is a massive trap you have to avoid: hypothermia. Severe burn patients have lost their skin's ability to regulate temperature. If you leave them totally exposed in a freezing trauma bay, their core temperature is going to plummet, which makes resuscitation incredibly difficult. So the golden rule: stop the burn, but immediately get them covered and crank up the heat in the room. All right, primary life threats are stabilized. Now we move into the secondary survey. This is where we conduct a comprehensive head-to-toe evaluation and gather the patient's history. We lean heavily on the ample memory aid to do this fast and effectively. A is for allergies, M is for medications, and definitely make sure you ask about herbals and over-the-counter stuff. P is for past medical history, including pregnancy. L is last meal or drink, which is absolutely critical information if they end up needing surgery. E stands for the events related to the incident, and hey, keep your radar up here for any suspicion of intentional injury or abuse. Finally, T for tetanus status. If they haven't had a shot in the past 5 years, they need an update. As you're wrapping up that secondary survey, you're going to need to dress the wounds. But listen, when it comes to wound care prior to a transfer, less is actually more. Do not delay a vital transfer just to meticulously debride a wound. And whatever you do, do not slather on antimicrobial ointments. Why? Because the receiving burn center is literally just going to have to scrub all that ointment right back off to assess the tissue depth, causing the patient a ton of unnecessary pain. Proper wound care at this stage is incredibly simple. Cover all the burn wounds with a clean, dry sheet, and use a blanket to keep their temperature up. That's it. Keep it simple, keep them warm, and keep the process moving. Which brings us to a major pivot point: fluid resuscitation formulas. Remember those baseline IV rates we started earlier? Now we have to adjust them based on the patient's specific burn extent. You'll calculate their total body surface area burned, or TBSA, using the rule of nines. Once you have that percentage, it's time for some math. For adults and teens with flame or scald burns, you take 2 milliliters of lactated ringers, multiply it by their weight in kilos, and multiply that by their TBSA percentage. Now for children 14 and under, that multiplier jumps to 3 milliliters. Plus, and this is key, they require D5-LR maintenance fluid because young kids deplete their glycogen stores incredibly fast. But pay close attention to electrical injuries. Regardless of the patient's age, the multiplier shoots up to 4 milliliters. Electrical burns cause massive internal muscle breakdown, releasing myoglobin that can quickly wreck the kidneys. They need a massive fluid flush to prevent outright renal failure. But remember, a formula is literally just an educated starting point. Once those fluids are running, you have to prove they are actually working. You titrate your fluids to meet specific hourly urine output targets. For your standard adult thermal burn, you're aiming for 30 to 50 milliliters of urine an hour. If you've got an adult with pigment in their urine, like that myoglobin from an electrical burn we just mentioned, you have to push fluids aggressively until they output 75 to 100 milliliters an hour, keeping that pace up until the urine finally clears. For kids, it's strictly weight-based, 0.5 to 1 milliliter per kilo per hour. At the end of the day, urine output is your ultimate physiological scorecard. Okay, so when do we actually pull the trigger and transfer? Let's look at the referral criteria. Guided by the American Burn Association, the absolute crucial threshold to memorize is this: greater than 10%. Any partial thickness burn covering more than 10% of the total body surface area warrants an immediate consultation or transfer to a dedicated burn center. But it's not just about the math. Specific clinical presentations also trigger an automatic referral, for sure. We're talking about deep burns on any critical functional or cosmetic areas: the face, hands, feet, genitalia, perineum, or major joints. It also includes all suspected inhalation injuries and all electrical injuries. And yes, that includes lightning strikes because the symptoms can be severely delayed. Throw in chemical injuries, kids requiring specialized pediatric care, and patients with severe underlying conditions or other traumas. Basically, if your patient checks any of these boxes, get the burn center on the phone immediately. Finally, let's break down the transfer process itself. Making the call to transfer is really just the beginning. A direct provider-to-provider handoff is absolute protocol. You and the burn center must collaborate to nail down the best mode of transport and any final stabilization measures. And here is a reality check on the legal and clinical front. As the referring provider, you maintain responsibility for that patient until the transfer is entirely completed by trained personnel. You can't just load them into a chopper and wash your hands of it. You have to back up the transfer with a comprehensive record: demographics, history, labs, imaging, and a highly detailed flow sheet of every single resuscitation measure you performed. Now, as we prep for this transfer, I want to highlight a really striking piece of data that might challenge how you think about airway stabilization. According to Romanowski and colleagues, quote, more than 1/3 of intubations in patients transferred to burn centers are unnecessary. Think about that. While airway management is absolutely critical, this data exposes a major tendency in our field to over-triage and unnecessarily intubate just because a transfer is happening. Intubation carries its own severe risks, right? So the guideline is clear: intubate only when it is clinically necessary, not just as an automatic reflex for transport. And this brings us to the core philosophy of burn management. A study by Sheridan and colleagues proved that early burn center transfer directly shortens hospital stays and significantly reduces complications. This is exactly why we prioritize rapid stabilization. Delaying a transfer because you want to clean up a wound or because you're waiting around for some non-essential lab result actively harms your patient's long-term outcome. Get them stable and then get them moving. So, I'll leave you with this final thought. When seconds count and the pressure is on, will you know exactly when to stabilize and exactly when to transfer? By following this structured sequence, relying on the precise fluid math, and trusting the strict referral criteria, you entirely remove the guesswork. Keep this roadmap in your mental toolkit, because mastering this exact process is what makes the difference between a tragic cascade of complications and a safe, successful recovery for your patient. Thanks so much for joining me on this explainer, and as always, keep learning.